So now let's move on to our main session. Our next speaker here is Dr. M. Thangapandi, who has worked as a critical care clinical pharmacist at Medanta Hospitals, Haryana, and currently working as a consultant clinical pharmacologist in infectious diseases at America's India Foundation, Panimalar Medical College and Hospital. And he was also the president of National Forum of Pharmacy and the regional student president at Center for Health Education and Awareness Resources and Services. It's a pleasure to have him with us today. Something I should say, he's in Rajasthan for a program. Besides its hectic schedule, without any hesitation, he accepted our request. Thank you so much for your time, sir. He's here with us to share his knowledge on antimicrobial spectrum versus resistance profile. Over to you, doctor.
Yeah, thank you, Mr. Santosh, for your kind introduction. So, and as he told, I'm a bit occupied recent days, but when it comes to knowledge sharing, I'm happy to do that. Okay, well, without any delay, we'll go to the session. My screen is visible to everyone.
Yes, sir, the screen is visible.
Yeah. So good morning, so good evening, everyone. So I'm here to speak on the topic about antimicrobial resistant and antimicrobial species spectrum. You might be seeing that the topic they have mentioned it bit kind of reversed here. Can anyone of you can tell me that what is antimicrobial spectrum before entering into the topic? Volunteers, please. Anyone of you? Okay, I am only telling. So when the antimicrobial resistance it is increased, so that time, so for every antibiotic, it is having an affinity to inhibit or kill the particular microorganism. So for some antibiotic, some microorganism, it will be intrinsically resistant to that. So in that case, we will be studying that specific microorganism or species to every antibiotic to know the antimicrobial spectrum. So when we are had the resistance, this antimicrobial spectrum, this we have studied a lot to overcome this antimicrobial resistance. Why this antimicrobial resistance came? Okay, we'll start from the basics because I don't know, because there is a variety of target audience here from my working professionals, interns, and fifth year, and all the years of pharmacy students. Okay, what is antimicrobial resistance? Here it is in, so when the any of the microorganism, either it can be a bacteria, virus, fungi, or a parasite, it is developed the ability to defeat the antimicrobials that is designed to inhibit or kill the particular microorganism. Okay, because it is hope my voice is audible to everyone.
Yes, sir, you're audible, sir.
Yeah, because when the particular microorganism is unresponsive to the which antimicrobials which are having to treat the particular infections, that the stage we calling it as an antimicrobial resistance. And another thing, it is what we are speaking about today. So most in nowadays, recent days, it is a multi-drug resistant. It is more common in every hospital which we are dealing it. So if we are seeing the patient culture, you will be having only few of the antimicrobials left which you can treat the particular infection, which is making the treatment option harder for the clinicians, and for the patients, the economical as well the hospital stay, it is economical burden as well the hospital stay, it is increasing. There is so many complications are there apart from this economical burden and hospital stay. Their metabolic actions, it will be getting compromised. Their immune system, it is under the pressure to perform over, and their inflammatory either it is a messenger or an inflammatory system, it is reacting more against our body sometimes. So the in a recent case of COVID scenario, we have seen that cytokine syndrome that time. So these are the things which we are facing because of this multi-drug resistant, extensive drug resistant, and pan-drug resistant. So in a simple logic, multi-drug resistant, it is the particular microorganism which is non-susceptible for at least one agent in 3 or more antimicrobials. Because if you are say it is why I have given it in one agent in a 3 or more antimicrobial classes. Because if you are seeing it is an some case of a multi-drug resistant, it is a methicillin resistant Staphylococcus aureus, vancomycin resistant enterococcus. So these kind of things are mainly resistant for that particular one microbial agent, but another microbial agents also has been resistant in the same time. But if you are seeing in the extensive drug resistant or multi-drug resistant cases, it is not the case. Either it is a minimum 3 or more the classes has been resistant in the particular case. Okay, what is the main root cause for AMR? So it is a kind of a basic concept. First, there is a lot of germs and infections are there. We had a penicillin and few drug resistance are there. A few patients experiencing and they are not getting cured earlier and all. And then we have only because previously there is some microorganism, it is inherently resistant to the particular antibiotic, but we didn't know the particular thing because the need of the particular research is not there in the earlier 30 or 40 years before. But now the thing it is entirely different. Okay, apart from that second point, it is antibiotics kill bacteria causing the illness, as well the good bacteria which is present in our gut flora or the which is causing it good to our body for absorbing the foods and so many things, minerals and all. Because when the drug resistant of bacteria now allowed to when we are not treating the particular microorganism, either it is inhibiting or kill the antimicrobials which is killing the microorganism that time. So we are not giving it is in correct dose or in correct frequency, or it is not de-escalated in the particular time because we are extending the microbial treatment prolonged when then it is recommended. So the drug resistant bacteria are allowed to grow and it is producing the resistance. So it is having a fine mechanism and I hope it is covered in the previous sessions. So I'm not going into the deep. So I'm just generally naming its few. One, it is an efflux pump mechanism, and another it is an alteration in the target site, and because that particular microbial agent, it will be having a low affinity in the particular microorganism, the binding site and all. And another thing, it is the there is a deactivating some enzymes will be there. If it is an some microorganism, it is there. It's a beta lactamase and all. So that's why in the initial case, the penicillin is not working for every patient and all. And some in another continuous process, some bacteria give their drug resistance to another bacteria. So to their plasmid, it is either it is in vertically it is transferred or in so many other mechanism where the resistance can be transferred to from one bacteria to another bacteria or virus to virus and all. And here we can see the so many important antibiotics which have invented in on some year and another it is get resisted. First time they have identified that this particular microbial agent is resistant for means being resistant for this particular organism. So you can see here that penicillin, it is invented in the year of 1940 and it is got resistant in the year of 1943. So it isn't quite quite faster because in the every species which is present in the world, the main priority is to the survival. So in order to survival, so the bacteria has developed resistance for the microorganisms to exhibit the particular to ensure the his survival in the world. So same like goods go for every organism, like even humans and some other species and all. So it is a normal process, but when it is getting increased, what will happen? Because why we are discussing it here every day that it is a global threat and it is in so many things we are discussing. Why we are discussing? Because we are having a limited number of antibiotic discovery these days. But the antibiotic which is getting resisted very faster. But when we are looking into the root So it is that we are not using the antibiotic in the rational use, as like Dr. Felix told. The antibiotic we are giving it to the viral infections, or it is used more than the expected duration and all. So it is not needed, and that is the main reasons overuse or misuse of antibiotic. These are the main reasons this kind of resistance have developed. So, but this ES which I have mentioned here, it is not complete resistant. So, when the first resistant organism it is identified, if we are, excuse me, so sorry for the disturbance, guys. So, if we are seeing the tetracyclines, which we are having a doxycycline and tetracycline, and then minocycline also in the recent days, because when it is identified, and another in the recent within a 10-year, every drug which is introduced here, on average, it is developed a resistance. In the case of methicillin, you can see here within a 2-year, it is developed the resistance. In a very sad manner, the levofloxacin developed resistance in the same year where it is introduced. You can see the vancomycin, imipenem, gentamicin, and ceftaroline, which is a 5th generation cephalosporin. So, which is introduced in the market in the year of 2010, and it is got resistant in the very next year. So, if we are seeing this data, it is derived from that source. It is CDC. So, where it is developed on more resistance. So, where it is, we are having the more data source from the all over the world. And another thing is, we are speaking about the resistance. I have mentioned that inherent resistance or intrinsic resistance in a previous slides. So we can see that by two main, so the previous they have mentioned about the types of mechanism which it is getting the resistance. Okay, what is the types of resistance? There is a two major class. One, it is an intrinsic resistance and acquired resistance. So there is a two different scenario, like we will be having a natural immunity and then acute immunity. So the natural immunity, it is the same concept of intrinsic resistance. So in that cases, the absence of target and then low affinity of target, low permeability through the cell wall of the particular microorganism, efflux mechanisms will be present. It doesn't mean that this characters only it will be present for the intrinsic bacteria. This have identified most commonly in the intrinsic resistant organisms, which is using this particular mechanism in vitro in the research labs. And acute resistance, either it can be created by the mutation, which is which is happening very quickly in recent days, and then added genes. So the modification of target, because when you are preparing one key for to open, you're having a key for your home, but it is modified by another person, you won't be having that much. You can't open your that particular lock that much quickly. And then added genes, inactivation of drug. So, and then modification of target, efflux mechanism. So this will be applicable for the acquired resistant as well. So the absence of target, it is the main thing which is differs from the intrinsic resistant and acquired resistance here. So till now, if you are having any doubts, you can unmute yourself and you can ask me. Because if you want to assess this particular data, so about the antimicrobial spectrum, so if you are having a very solid database where you can get the almost most of the antibiotics, antifungal or antiviral. So whichever the drugs which is introduced in the world market till date, you can get from the manufacturer or from the FDA. If you are putting that particular microorganism, sorry for that, on putting that particular antimicrobials, either it is an antibiotic or an antifungal, along with that spectrum of activity, or if you are mentioning just the particular antibiotic name, ceftriaxone, FDA, if you are mentioning, there will be a complete prescribing information. So that is the one particular document where the most of the PharmD who is to do the excel in the clinical areas, they should know. In that you no need to, that will be an about 10 to 15 or more than 20 page document, but you need to know that there will be an concise information in the first page, that is about 13 to 17 informations. You should know it completely, so then only you can suggest something, or if you want to argue for the patient welfare, that time you can, but it should be in healthy, not supposed to be that egoistic thing, because when you want to make the changes, it should be happen, but it doesn't mean that I should argue or not. There in our antimicrobial stewardship, there is one word, handshake stewardship. So where you will be conveying that those things with an evidence, with the when you are proving yourself with them, because when you are taking a rounds along with them, you are giving your findings to them, automatically they will accept you. Initial days it won't be there, but it will take time, but it needed to be done by every formed person, because we don't have any thing to make a decision. We are the suggestion makers, and most of the things, because the decision making authority, it is not in our hand, that we need to understand. Okay, we have speak about the mechanism, and then resistance types and all. So here we can see that which antibiotic it is developing a resistant by which particular mechanism. So you can see that here beta-lactam antibiotics and chloramphenicol, it is almost developing the resistant except the efflux pump mechanism. Here you can see that modification of the particular antibiotic that site, drug site, or that inactivation of the particular organism. If you are seeing that in some microbial microorganism, that is inactivating by producing the beta-lactamase enzyme. In some of the things, the efflux pump mechanism, it is there, example tetracycline. So if you are seeing beta-lactamase antibiotic and then chloramphenicol, which is resisted by the mechanism of target site alteration also, and we are seeing that reduction of the in the cell surface permeability, because it is not only about the so many things, because we need to know in which mechanism it is getting resisted. If you are speaking with the doctor, if you are know these things, excuse me for a minute. Here, hope my voice is audible to everyone.
Yes, sir, you're audible, sir.
Yeah, thank you for that. Yeah, because we are seeing that metabolic bypass mechanism. So most of us we have studied about that first pass metabolism. So it is where the oral formulation is getting metabolized by in the first pass metabolism, and IV it is getting bypassed and all. So the same it is this particular new metabolic bypass mechanism, it is identified in a recent years. So that is how the trimethoprim and sulfonamides it is getting resisted. Because in the most of the culture reports, you might have seen that these things are trimethoprim, sulfamethoxazole, it is remain sensitive for the most of the organisms, but it is not going to be same anymore. Okay, I have explained you about the intrinsic resistance, which is for the some antibiotics. The microorganism, it will be intrinsically resistant to the some antibiotics. So I have listed a few of the things here. If you putting some random particular microbial agent name, and if you have intrinsic resistance, so you will be getting it from the Google. So that if you are seeing that all gram negative, it is in intrinsically resistant for vancomycin. In the same case, all gram positive organisms are resistant for aztreonam and then polymyxin B and all. So you can read it out if you want. I will share this PPT with your organizer. You can make use of it. And aerobic bacteria, which is resistant for metronidazole, salmonella for an aminoglycoside. The patient is coming to the hospital with a salmonella type infection, there is no point to give the particular person aminoglycoside antibiotics. So and then we have speak about spectrum of antibiotics, because we have studied that a particular antibiotic is sensitive or not, but when it is getting the more resistant in the nature, so that time we have studied about the for each antibiotic what are all the microorganism it is sensitive. So and then that same thing that Dr. John Felix has said in the previous slide, so where you can see that MRSA, it is resistant for sensitive for vancomycin, ticoplanin, and linezolid, and daptomycin, and all. Can any one of you tell me that can we use? I have listed out 4 to 5 antibiotics name for the MRSA infection. Linezolid, vancomycin, daptomycin, ticoplanin, and all. So apart from these 4, so can you name any one of the antibiotic which we can use to treat MRSA infection? Any one of you from the audience side? Yeah, Tirumala's kindly Subhapriyan have answered about clindamycin. So I have already told about the vancomycin. So okay, I'm telling it. If you want to unmute and can unmute and answer. Yeah, kindly unmute yourself, Tirumala's, and answer. Okay, I'm only telling you. So you might have heard about the doxycycline antibiotic, so which we are not considering recent days to treat the MRSA infection. So we can use the doxycycline and BLA antibiotic, pybrazinate tazobactam, where it is can be used for an anaerobic coverage as well the MRSA treating infection. Because when you are speaking with the physician, so that time you have to convey them, sir, can we give a try in that particular, not only about the sensitive pattern, you can call them, you can tell them this suggestion, sir, can we try pybrazinate tazobactam for this patient? Once you have a good rapport with that particular physicians, you can give them this kind of things. These are out of box answers which will be helpful in physician in some rare cases. Okay, and I'm coming to the topic that antimicrobial spectrum of an antibiotic means the range of microorganism it can kill or inhibit. Because we are by the spectrum of action, we are dividing the antimicrobials in 2 main categories. One it is in broad spectrum, and another one it is in narrow spectrum. So because we are seeing about broad spectrum and narrow spectrum, so that time it is differs. Why? Because in a narrow spectrum, it doesn't mean that narrow therapeutic index. It is covers only very few organisms. So the narrow therapeutic index, it is also having some other parameters along with the spectrum. Because if you are seeing the vancomycin, it is not going to cover a gram-negative infection, or it is not going to cover so many infections in the gram-positive also. So it is having a limited limitedly available to treat the infections. So that is the only thing about the narrow spectrum antibiotics. And another thing it is broad spectrum antibiotics, which is having a wider range of bacteria coverage. It is a gram-positive and an anaerobic and then a gram-negative infection. Because we are categorized, this is for our comfort. One it is gram-positive, if you are having an idea about the gram-positive infection this comes, so which are the antibiotics are available to treat, like how we are differentiating about the gram-positive and gram-negative. So here you can see the slide. So where I have the slide has showing you that from the narrow spectrum to very broad spectrum antibiotic. So here they have mentioned that not in the exact order, but it is in almost correct order, because you can see here it is in more than yellow according to the WHO aware classification. Meropenem and carbapenems are in a watch class, and then reserve, you can see here that reserve class of drugs, which is in the most of the hospital, it is in the almost red as well the red category. So that is cyclin, phosphomycin, colistin, polymyxin B, vancomycin, ticoplanin, and linezolid. In where we can this is all about the antibiotics, but there is an antifungals as well. So then casfofungin and then micafungins that need to be added, because in a access or a watch class there will be a fluconazole, ambidoracin B, and all. Okay, so that is the cases here. But when you are speaking about speaking to the physician about the escalation or a de-escalation, it is a main major thing that you have to notify certain parameters before suggesting that. First parameter that that patient not supposed to have a fever spike within a 24 to 48 hours. If the patient is clinically stable, then it is fine about the 24 hours. And the patient's inflammatory markers, it should be in the downtrend. So because and I'm giving an example. So the when the patient admitted, they might have tested for then CBC, where we can see the inflammatory markers WBC and then neutrophils, and then procalcitonin, and then D-dimer, D-dimer and procalcitonin, and another test. These are the inflammatory markers, and then CRP. So these are the things which we can say that not only by seeing the patient, either clinically with the lab evidence, we can say to the physician. And another thing is for sepsis patient, in the time period of 48 to 72 hours before the culture report arrives, even though the patient is improved a lot, or the patient had a better outcome, the patient doesn't have a fever spike or all other categories, you're not supposed to suggest the de-escalation, because when we might not seeing the symptoms of sepsis, but the sepsis which can like an UTI infection, which can reoccur in any moment, especially in the pediatric cases. So we are telling those things, it will be a wrong call. Anyway, they are not going to make the call, but that will reduce your professional image among the clinicians as well, your fellow colleagues. Okay, and another case, it is about this two category disorder, and then the patient is on mechanical ventilation support. If the patient is on ventilator or on that oxygen mask in a high liter, because oxygen mask, it is having a capacity of holding about the 5 liters. If the patient is on 5 liter high flow in a high flow in the oxygen particular mask, so we not supposed to speak to the physician about the de-escalation. It is not the right time. Maybe you can give speak about the de-escalation to the another antibiotic after 1 or 2 days, because if the in the only case the culture report suggests you that the same antibiotic, it is sensitive, even though the patient is not improved, but they need to escalate in any antibiotic, that time you need to speak with the physicians, or the patient is condition, it is decreasing, the prognosis is not getting improved, so we need to switch the antibiotic. That time they will definitely switch it, but by seeing an MIC value, you can suggest them the better action, that which antibiotic they can switch it. That is the thing, because if you are seeing that amikacin here, you can see on another side of the slide. Hope you can have a better view about the slide. You can see that like an vancomycin, amikacin also doesn't have an gram-positive organism, but you can surprisingly see that gentamicin, it is listed before the amikacin. But because gentamicin, it is having a gram-positive and gram-negative coverage. So not a gram-positive and gram-negative coverage. It is having a gram-negative coverage, but it doesn't have the narrow spectrum. It is covering the more species of the microorganism, or a more number of microorganism. Okay, if you are seeing that, you will be having a clear-cut idea, which is not having any gram-negative coverage. If you are seeing that benzyl penicillin or penicillin and vancomycin, linezolid and ticoplanin, it is not at all having a gram-negative infection, gram-negative coverage. And sorry, organizers, please ensure that there is no disturbance for the session. Gaurav, please mute yourself.
Participants are requested to mute their voice.
Hope you people able to follow me till this slide, because I will be sharing this slide. If you want, you can go through all these things. I have attached the reference as well at the end of the slide presentation, because your organizer are very keen about which need to be delivered to the participants, and I am appreciating his effort what need to be delivered. Okay, and another thing, it is which microorganism. Okay, we have speaker about the antimicrobial resistant and its types, and what is about the antimicrobial spectrum and which antibiotic falls in a narrow spectrum and all. We can see that antimicrobial resistant, which is having an MDRO infection. These are the main MDROs which I have dealing with it in a regular basis. When it is in methicillin resistant Staphylococcus aureus. So I am telling you about quick view about this particular methicillin resistant Staphylococcus aureus. Staphylococcus aureus, it is a gram-positive microorganism. So that is initially resistant for the penicillin in the initial days. So after that it is being resistant for the methicillin as well after some years. So it is being resistant for the methicillin. So it is named after the same particular antibiotic, methicillin resistant Staphylococcus aureus. Okay, and another thing it is vancomycin resistant Enterococcus. So we are seeing that it is even though it is in rare care, but if it is happens in the particular hospital, it is kind of an local emergency, because this happens in a very rare scenario, but it is not a good sign of the better infection control practices as well the antimicrobial stewardship practices all over the hospital. And in recent days, it is increasing in a very large account because of the overuse and misuse of the ceftriaxone in a OPD as well IPD basis, because extended spectrum beta-lactamase producing bacteria. So that is resistant for having so many classes, because almost every bacteria which can produce the extended spectrum beta-lactamase producing bacteria. If it is in some antimicrobial agents, it is already having the basic criteria for to see the resistance to categorize this particular resistance. So third generation cephalosporin, ceftriaxone, it will be resistant, and then BL-BLA antibiotic, pybrazinate tazobactam, and then cephalosporin sulbactam, it will be sensitive in the same culture. This is where you can identify the ES, that is an ESBL resistant mechanism. Or else they, if you are in the hospital, they might have mentioned that this is an ESBL resistant particular organism, and then MRSA and then MDR, XDR and all they will mention. It completely depend upon the microbiologist and physician what can say coordination, and then better the things to know about, because or else they will be releasing to the only to the treating physician directly about this kind of resistant or an MIC values and all. And the types of patient having a high risk for an MDRO infection. So all we know that hope you guys aware about the patient type category. Can I hope the PharmDs are there and so many persons are here. So can any one of you say that in hospital setting, if you are seeing the patient admitted in the hospital, how will you categorize the patient? Most of you doing your internship and working in the hospital setting. Can any one of you name the category and how will you categorize the patient? So I have given the clue. There is a 4 category. So it is a simple thing.
You mean,
Yeah, Gaurav Memane, you can answer this.
Sir, there are 4 category for the antibiotic choice. There is class first. There is a patient who are coming to the hospital, who are not admitted to the hospital less less than 60 days in a month.
Yeah, Gaurav, you continue, please.
जो पेशेंट है सर वो 60 डेज के अंदर हॉस्पिटल में नहीं आना चाहिए. उसके बाद
ठीक है,
उसको
ठीक है.
कोऑर्डिनेटिस नहीं चाहिए, लाइक डीएमएसटी ने होना नहीं चाहिए. ये हो गए क्लास 1. इन सेकंड क्लास
Now, one minute. Gaurav, sorry for the interruption. Can you convey it in English, because there is so many people who is not able to understand Hindi.
No problem.
Telugu peoples are there and Kannada, Tamil, so many persons are there. Please, or you can explain it in Hindi. I will convey it for them. Please go on.
Then second category is who patient who are admitted to the hospital who is greater 60 days in the hospital, and who are no receiving any antibiotics in the last 60 days, and patient who are not any comorbidities like DMSTN. There is a second category, and third category is a patient who are coming to the hospital and who are admitted in 1 month, and who are a patient is like comorbidities like DM, HT, and hypertension, and who are receiving the antibiotic in last 10 days. There is a third category, and fourth category who are patient admitted and they have a procedure for any treatment like any surgery happen in the hospital. There is a third category, and who are taking the who are patient are taking the antibiotics in last 10 days. There is a fourth category. So choice of the antibiotics.
One more thing, it is the patient is immunocompromised or the patient is receiving in cancer treatment. That
Yes.
patient also falls in a category 4. Guys,
Yes.
I just want to summarize what Gaurav told. Before that, if anyone want to share their view, they're most welcome. Tejasvi, you are telling something in the text. Better you can convey it to everyone. So okay, I'm coming in for all of you people, behalf of you people. Okay, first category is the patient not admitted in the hospital for an past 1 month or 30 to 90 days. The patient not on antibiotics, either in an OPD basis or an IPD basis, that same category. And then patient is not having any comorbidities or not went any surgical procedures in the last 3 to 6 months. And another thing it is second category, where it is the patient is either visited the hospital or received the antimicrobial, or the patient is have any comorbidities and all. So that is the category second. And if you are seeing the third category, that the patient is discharged from the hospital within a week, or the patient underwent any infection which is diagnosed with a evidence based thing. So that patient falls under the category 3. So where they may be under the oxygen support, or the patient's inflammatory markers maybe went up to the very abnormal level and all. And the category 4, as like I mentioned earlier, that is an immunocompromised patient, the patient receiving an oncology treatment, and the patient who is having an febrile neutropenia. So those are the patient falls under the category 4. Before deciding the empirical treatment, these are the one of the vital things which need to be monitored from our side. Clinicians will know these things, because when the patient is transferred from another hospital with the known case of sepsis or some other comorbidity, some other uncured infection and all, so that patient also falls under the category 4. Or the patient is who is undergoing the surgery, major or minor. So that sorry, not a minor. So that patient and all falls under category 4. Okay, we'll continue with the presentation. It is good interaction, guys. Oh, sorry, guys. Can you able to hear me that I have explained you people about the 4 category? Or my voice is not audible for 1 or 2 minutes. Can anyone of you confirm it?
So your voice was audible, sir.
Okay, previously when I was explaining it, the 4 categories, right?
Yes, sir.
Okay. Thank you for that. And another thing, it is an underlying disease condition such as diabetes, like comorbidities, common comorbidities in India, chronic kidney disease and skin lesion. In recently that our India has been an onco capital of the world. So that cancer capital of the world. It is a very sad news because of so many reasons, underlying reasons. It became like that. As a young generation, it is our responsibility to take care of ourselves as our the people, loved ones, and then who is in and around. You can see my screen now.
Yes, sir. Now it's visible.
Okay. That another thing, it is an invasive procedure. If the patient is on dialysis, or the patient is on a catheter like an urinary catheter, or the patient is they have incident central line or peripheral line. So those things are all having a higher risk of infection, because when the patient body, it is we are making any cut, either it is in surgery or it is in by inserting a line for an administering in high concentrated electrolytes as well the antibiotics, some concentrated drugs. So that is the thing. And repeated contact with the healthcare system, because either the healthcare workers, it is a kind of one thing which is in sad part, either the particular person is a microbiologist or an ID physician or they are working in a high risk areas like emergency and high ICU and all there. So that's why we are telling that that infection control action, it is more important for the patient, and we need to prevent the infection from us to the patient and from the patient to us. So that is a vice versa concept. And then long stay in hospital, either the patient is a geriatric patient or the patient prognosis is not improving and the patient is having recurrent infection. The long stay of the hospital is a very high risk from this all these one of the high risk reason from this for the MDR infection and the previous colonization of with MDRO. Why this case will happen when the patient, especially on the catheter, because and this condition not supposed to be treated, because if the patient is on a colonization, you can see if you are a microbiologist or in a microbiology department, it is mentioning that colony count, because more than 10 power 5 to 10 power 7, it is an infection, clear infection. If the colony count, it is in 10 power 2, 10 power 3 and all, it is in colonization. So that time if the physician it is switching the antibiotic, we need to convey them, sir, it is in colonization, there is no need to treat. But before that, you need to learn all these things in a thorough manner so that you can present yourself in a better way. So any immunosuppress means the patient is on immunosuppressive medicines, or like the patient is elderly, about more than 90 years or 80 years. So that is also the patient who is having a high risk for an MDRO infection in a hospital setting, or the patient is having in comorbidities and all. And okay, we have spoken about so many things about the antimicrobial resistance. Here we can see about the genotype, which is not exactly happening every patient in India, but where you can have some knowledge about which resistant gene can be reason for the behind this particular multi-drug resistant. Because when you are speaking about speaking to the physician, they will know about these things while they are studying for their MD as well the fellowship. So that time, because in a clinical setting, when they are thinking this guy knows something, so that we doesn't know, or that sometimes we are confusing. This guy is readily available with the information, or we can confidently ask that particular person about any kind of discussion, open discussion. So that is more important. And Staphylococcus aureus, that is MECA gene. So that time you need to understand what it is an abbreviation first. Methicillin A gene, it is in reason for this particular resistance. And then for VRE, it is in phenotype, it is in nothing but the resistant type. So vancomycin A and vancomycin B, it is decreasing the affinity of the vancomycin, which is can bind to the Enterococcus species microorganism. And then ESBL, I have mentioned earlier, it almost every every microorganism can produce ESBL, but it has been identified in this organism most commonly, CTXM. And then E. coli, it is having NDM. So can any one of you unmute and say what is NDM and where it is identified first? Hope you people are aware about these things.
New metala beta lactamase.
Yeah, where it is identified, it's good, correct only. Okay, and that is an identified in New Delhi.
New Delhi, yeah.
Yeah, and another thing, it is in that particular time only. It is in almost in 5 to 10 years back. It is in where we have experienced extensive drug resistance that time itself, because we are not only leading in the population over the means from the leading the world, but it isn't about the resistant antibiotic consumption. All in all, it is not at all a good things we can have a pride on ourselves. And OXA48 as well. So OXA48, which we can commonly see in this kind of categories like an extensive and a drug resistant, because these are the most frequently reported organisms in the hospital setting. That's why I'm discussing with you people. And we will be discussing that every organisms I have explained here, that 4 major drug resistant MDROs, which is the day-to-day healthcare persons which we are facing as an antimicrobial stewardship clinical pharmacologist. I am also facing the same. So the methicillin-resistant Staphylococcus aureus, it is first identified or isolated in the year of 1968 in the US. Those Staphylococcus culture specimen that tests an ampicillin resistant or an cefoxitin resistant or an methicillin resistant by an susceptibility test. Because I have, as I mentioned earlier, to confirm this is a methicillin resistant Staphylococcus aureus, because the microorganism will grow in the culture. But you need to diagnose, right? Okay, there will be a confirmatory test for everything in a clinical setting, especially. So that is the thing we need to confirm. For an MRSA, either it need to be an cefoxitin resistant. First, they will in a lab. We might not see in all the reports about the cefoxitin in MRSA, but first they will, if they are suspecting about MRSA, they will go with the cefoxitin resistant in the most of the lab. Ampicillin resistant also they will do, but when I speaking with the microbiologists, they have told about this ampicillin resistant. Okay, and another thing, it is an FDO. It is approved the direct sampling of PCR, because whenever we are speaking about this antimicrobial resistant, and it need to be prescribed, that culture need to be sent first, and then after that they need to go with the empirical treatment, and it need to be de-escalated, and it need to be IV to oral and all. So that time it need to be very quick, because in a recent scenario, the patient is coming with an sepsis shock or an hypoanemic shock or an road traffic accident, we will be having lesser time to recover the patient. So that time we might have starting the higher end antibiotics which is available in the according to the patient category. But when we are having the, according to the resistant rate is increasing very rapidly, so we need to ensure that the diagnostic test also it is reported in a very frequent manner, because in recent years the diagnostic like an antimicrobial stewardship, diagnostic stewardship also it is getting increased. It is getting increased, and then that I will be explaining it in the later slides, because where you will be seeing this, but there is one particular equipment, that Gene Expert, and so many equipments are like that, where we will be getting an particular microorganism or a particular resistant pattern, like I have mentioned earlier, NDM, CTXM, or OXA48, that's kind of including with that and genomic resistant pattern within a few hours. So that is the thing. And methicillin resistant, commonly it will be resistant to the penicillins, cephalosporins, and monobactam. Monobactam is an Astrionum, carbapenems, all three it will be, and macrolides, and then lincosamide. But it's not necessary that in every case of MRSA it will be resistant, but in the most of the cases it is used to like this. And a vancomycin resistant enterococcus. In this major thing, it is an Enterococcus fecalis and faecium. This is one of the factor where we can ensure the most of the hospital antimicrobial stewardship or an infection control practice, either it is at least not in the best part, or at least up to a moderate or mild to moderate level. Why? Because this Enterococcus fecalis and faecium, it won't get resisted to penicillin in that in a not like in other microorganisms. It will be resistant to the microorganisms in a very to the penicillin in a very rare cases. If it is if we are receiving that Enterococcus fecalis and a PCM, so which is frequently resistant for penicillin in a hospital, that microbiologist will convey it to the hospital team, either it is an HEC meeting or it is a consultant meeting or an antimicrobial stewardship committee meeting. So we are receiving these kind of rates in the past 6 months, 8 months. So that time we need to perform, and if some of the antimicrobial resistance it is increased in that particular period, we need to perform an restriction of that particular antibiotic, which is used in a very the top 1 to 3 antibiotics which is used in a very high number according to the resistance. So that need to be not prescribed for 90 days. That is a prescription restriction policy. So where it has been believed, it is not proved, but it has been believed that for a certain period of time, the antibiotic is not contact with the microorganism. They are become sensitive for the same microbial agents again, like a nitrofurantoin is used to resistant in earlier days for all over the things. But in the cases of in the era of XDR and pan drug resistant, it is become sensitive for the nitrofurantoin again. Like in doxycycline, which we are thinking that it is a narrow spectrum antibiotic, not at all like that. And then ceftriaxone doxycycline is which is prescribed in OPD basis of the patient coming to the hospital within not in having things just within simple fever spike. They didn't ready to make the proper diagnosis, either it is in viral or in fungal or in some other colonization or due to some other factors. If the patient is having a fever or some other symptom, it doesn't mean that the patient is always having an antimicrobial infection. Okay, and then it will be usually resistant to penicillin, cephalosporin, carbapenem, monobactam, and vancomycin. It almost that access to watch, because for half of the antibiotic which is available in the hospital, it will be resistant. And carbapenem resistant Enterobacteriaceae. So here you can see that carbapenem resistant, because carbapenem that is having 3 to 4 antibiotics. So it is most probably we will be using meropenem for an intra-abdominal sepsis, or an imipenem for an respiratory infections, and then ertapenem for an urinary tract infection. Doripenem, it is a very last result of the one of the carbapenem, which is used for another things. Another thing it is you need to understand, so that carbapenems also resistance also produced, because whenever you doing the action, there will be an opposite action, right? So like in the cases it is like that. Okay, we are almost running out of the time. I'm making the slides a little bit faster. Hope you people can able to follow it. And then ESBLs, as like I mentioned, so many organisms, so it can produce the ESBL, particular extended spectrum beta lactamase producing. Then it can produce it, though by the mechanism of hydrolyzing the particular antimicrobial agent with the bacterial enzymes, especially it is in first, second, third generation cephalosporin and aztreonum. So it will be resistant. Why? Because aztreonum, it is not having a coverage with the most of the gram-positive antibiotics. So it is in general criteria. It is a resistance of ceftriaxone or a cefotaxime is the screening criteria, as I mentioned for rest of the things. And MDRO. So as we are speaking about, it need to be resistant for 3 antibiotics or more. So here we can go in a proper way that resistant for 3 or more antibiotic, or an intermediate also it can be taken in the account. In the case of not in every case. So here you can see some of the antimicrobial classes. So it following 6 classes where we can confidently say that if it is in resistant or intermediate for these 3 classes, it is taken into the account of multi-drug resistant organism, because Acinetobacter baumannii or Acinetobacter species which is frequently reported in the ICU area. First it is lactamase antibiotics like in piperazine, tazobactam. So and there is so many things like in beta lactamase antibiotics, it is in penicillin, also carbapenem also comes under this aminopenicillins, and then cephalosporin, it is in ceftazidime, bactam, cefepime, because I have mentioned the class as well the most common drugs which is resistant. BLBLIs, piperazine, tazobactam, and then carbapenems, all 4 come together. All 3. And ertapenem we won't be seeing in resistant in so many things. But if you want to mention the class that if they have tested for all 4 antibiotics, it need to be all 4 need to be resistant. If any one it is an intermediate, you can take it as an resistant, complete class resistant as well. Aminoglycans is also resistant, and fluoroquinolones also as in out of these 6 I have mentioned that A, B, C, and out of these 7 classes, any 3 need to be resistant. Okay, so hope you can see the slide. So the burden of MDRO. So I have mentioned that the patient having a financial burden, and the patient strength will, length of stay will increase. But you can see all other things apart from the 2-3 things. Because antibiotic, the only thing where if you are treating one patient with the antibiotic, it won't be always available for treating the another patient in most of the cases, because this will developing in resistant mechanism all over. But if it is not used in a proper way, it will resist make the resistant in a very fast manner, and it is an hampers the control of an infectious disease, because it won't be good that if you are an infectious disease person seeing this the reality about the things, how the antimicrobial resistant it is holding the patient means outcome and all. and it is an increase is the cost of healthcare, because recent time we have seen there is so many inflations and all there, and the cost of treatment it is getting increased and increased. And then it is an AMR ultimate, it is a silent pandemic. Yeah, because we have discussed about the antimicrobial stewardship, but most of us left that particular antifungal stewardship, antiviral stewardship, because in a hospital there you are not for bacterial they will be sending culture, but in viral culture and fungal culture they are for some of the patient they are not sending and they are treating it, because bacterial infection it is a lethal one. I'm not denying it, but fungal infection it is more lethal than the bacterial. Before you diagnosing it, the patient will die. Why? Because the once the till the culture report arrives, it will take 10 to 15 days. And how the AMR is increasing. So as like I mentioned before, you can see here how the resistance pattern it is there. So antibiotics, which is here you can have a better action. So it is in pharma plant where they have manufacturing it. That waste it is, they have uh, excreting it to the either it is in the river bed or the nearby pharma land. So that time the animals consuming it indirectly. So that we are also consuming it as an food. So that also it is getting improved. Even household waste and hospital waste can also transmit the resistance. Here you can see it is in Times of India paper. So where animals consume 3 times more drugs than us, because they are consuming it from the environment. For some of the causes, it is the animals also feeded by the antibiotics. From the 2000 to 2018, it is an increased more than a 50% in the antimicrobial consumption of the food. In food that it is consumed as an animal part, either it's a meat or so many things. And the various possibility of spread of AMR. Sorry, this is an you can see that pathogenic microbes, it is an published an article which is in a BMC journal. So pathogenic microbes containing contaminating mobile phones in a hospital environment in Northeast India, incidents and antibiotic resistance, because apart from all other agents, our phone it is the most infected thing, because this is the hidden facts which we won't give that much attention to it towards it. You can see that pharmaceutical pollution it is causing the the animals also using, and then it is disposal also, either it is consumed by the patient or in a hospital, so many things. And you can see here that resistant it is hospital wastewater system, because before it is excreted in the environment, it need to be treated in the very good way. And then clinical and economic burden of AMR. Here you can see that it is in a slide adapted from the CDC. So where you can see the it is in last year data. So where you can see the 28 lakh 68,000 infection, out of that 35,900 patient died only because of this complex resistant patterns. Okay, and then clostridium difficile it will be like when you are using the higher end antibiotic irrationally, that time this infection will happen. That also more than 10,000. It is not a number, guys. So that it isn't maybe looking it maybe look like a number. When our generation or our family members have means having this kind of infection, that time we will come to know the hard reality. Then mortality rates. So this particular thing it is published by WHO. So they have expected that in 2050 average in an semi-developed or fully developed countries, it will be like in 10 million deaths over a year. Okay, the antimicrobial resistance alone causing this. Apart from that, comorbidities are there, cancer are there, and then upcoming pandemic or an endemic, epidemic. So many things are there. You can see the agent, the things which is causing. Apart from this, 8.2 million it is in cancer and also many things. And you can see recently WHO has released an that high. So what can I say? The major concerning organisms in 2024. You can get it in the website, because this is an old, a little bit older, which is released a year or previous year more. Here we can
Sir, your voice is not audible, sir. The speaker will rejoin with us, so I ask the participant to have patience and wait in the meeting.
Sorry guys, my Wi-Fi got disconnected here in between the power cut. So
That's okay,
it.
sir.
Okay, finally, so where I did the connection it is lost. Are you people see this impact of new diagnostics and all? Or you people didn't? Santosh Kumar, can you confirm? Did I explain this slide when I'm connected with you? Sorry, I didn't may share the screen like before.
Yes, sir.
Okay. Did I explain this slide while you connected with you people?
No, sir.
Okay. Here you can see that the resistant it is connected interconnectedly, that people, animal, and environment. If you seeing that CDC or WHO website, you will be having more idea. And it is an alternative therapies for tackling this antimicrobial resistant phase therapy. It is a more advantaged ones, that immune stimulation, antibodies, peptides treatment and all. And then I'm finishing my presentation with this on last case discussion. So here you can see that 88-year-old male admitted in the hospital, diagnosed with an aspiration pneumonia and cerebrovascular accident. So the patient inflammatory markers are listed here. Sorry guys, sorry for that. The procalcitonin unit and WBC. WBC it is in 30.69 per microliter, and then CRP it is in 220.92 milligram per deciliter. These are very high ranges, so you can compare with the normal ranges. And then the culture report which we have received, it is in Klebsiella pneumoniae, so which is leading cause of pneumonia in the hospital setting. So then pan-drug resistant it has happened. So can any one of you tell me that which will be the drug of choice for this particular condition? I just want to say know from you people, and I'm going to wind up. It is already 5 minutes more here. Yeah, guys, kindly tell me. So for an Klebsiella pneumoniae, it is resistant. Patient inflammatory markers are up to very abnormal levels, and the organism it is in Klebsiella pneumoniae, pan-drug resistant. Can anyone of you suggest which combination of because in pan-drug resistant it need to be treated with a combination of antibiotics. I'm giving you the clue, so kindly suggest me that which you will be suggesting to the physician in this case. So ceftazidime, avibactam, normally it won't be working in that much case, because another person have alone you can't give it for the pan-drug resistant. Another person mentioned that aztreonam as well. No, it is not that much recommended. because when you are going for the respiratory tract, osteotomy doesn't have that much penetration when you're comparing to another high-end antibiotics. Yeah, guys, kindly explain. Or if you're having any other suggestion, kindly unmute and tell me. With this, I'm winding up. So okay, I'm telling the answers if you are not telling. No, alone we can't treat. This is an pan-drug resistant. It is not an extensive or multi-drug resistant. So I'm. If anyone want to answer, kindly unmute because I don't have any time. It's almost 10 minutes late. Guys. Okay. Cephalosporin. No, not at all. Any other persons? Okay, I'm telling you people. So foreign Klebsiella pneumoniae. So that minocycline, it is having a better penetration into the respiratory tract infection. So that respiratory tract among the tetracycline category. And then another drug, it is in polymyxin B. It is also having a better penetration and then better gram-negative coverage. So that can be combinationally treated with then polymyxin B as well the minocycline. So you guys do remember one thing. In the aspect of combination of treating the antibiotics or in higher end antibiotics, the loading dose need to be given. It is not a fixed dose and 15 lakh international unit or 10 lakh international unit for a patient. Either polymyxin or colistin, so many things. It need to be purely weight-based thing. That time only we will be having a better things. Yeah, guys, it is an end note. It is a summary of the things like MDRO. It can't be effective without reducing the antimicrobial resistance, and we need a multidisciplinary action and better IPC factor. The diagnostic stewardship also need to be done, and then One Health. Some of the idea, it's like I mentioned, you can check it in the Google. Yeah, these are the reference CDC and WHO. Some other things. I will be sharing this with you people. If you're having any questions, I'm happy to take, and I'm going to wind up if you don't have any questions. Questions, please, guys. Felix, I'm not able to see the screen now. So if anyone of there posting their comments or question, kindly let me know. Hope you can hear me. Felix?
Yes, sir.
Yes, sir. I can hear you.
Okay, is there any questions till now?
No, sir, not yet. No questions right now.
Okay, guys, thank you for your time. I hope I have teached you something. And from my experience, I'm telling you 2-3 points. Before speaking with the physician, confirm once or twice. I'm not telling that you're not supposed to speak with the physician wrongly. Better if you can speak, confirm yourself, and if you're speaking it, that will increase your confidence level. And as an clinical pharmacologist, we need to bring a lot to our particular position or in our cadre and so many things. This is my contact details about the LinkedIn and mail ID. So that will be shared by Felix, who is an organized with this thing. And thank you, Felix, for inviting me. And I have shared some things with the students. Hope I have covered some areas which they don't know, because the target audience are very vast, and so I have prepared in that way that from the basics. You can connect me with the feedbacks from the audience.
Yes, sir. Thank you so much for your time and sharing your insights, sir. Thank you.
Okay, guys. Thank you. So then I'm...
Yes, sir. Thank you.
Okay, guys.
Yes, sir. It was actually a very informative session from you, sir. And I hope like not only the students, but also the working professionals have many take-home information from your session.